medicine specialist at OrthoVirginia, located here in Virginia Beach. We're going to talk today about the meniscus. Meniscus from A to Z, friend or foe, you have it. We'll talk about it all, trying to answer all your questions. As a background, the meniscus is one of the most commonly and frequently injured structures in the knee, and the knee is being one of the most frequently injured joints in the human body. You can get meniscus injuries when you're young, all the way to your elderly years. The reason for that is that the meniscus is the anatomy of the meniscus. So we're going to go over that here to make you familiar with that. Just as way of background, the meniscus surgery is one of the most common surgeries orthopedic surgeons do. The medial meniscectomy, arthroscopically done, is done over 500,000 times a year. So let's introduce you to the meniscus. The meniscus, there are actually two meniscus, or menisci, in the knee. There's a lateral meniscus, which is more circular, and a medial meniscus, which has more of a C shape. Both of these menisci are attached at the front and back of the knee. They have bony attachments. In between the two bony attachments, or roots, are soft tissue attachments. So that creates a very mobile structure that is good for translating during range of motion activities, but makes it more susceptible. Fibrocartilage starts out very tough, and as we get older, the fibrocartilage becomes more brittle and more easily torn. So when you're young, it takes quite a bit of trauma to cause an injury to the meniscus, such as an ACL tear or high energy sports injury. And when you get older, you can tear your meniscus just by squatting down to pick up a dog toy. So the meniscus has two functions. As you can see, they're semicircular, but there's no meniscus in the center, except for by developmental variation. That's something different. We're not going to get into discoid meniscus at this time, but basically the meniscus has a central area where it's hollow. That accommodates the curvature of the femoral condyles. When the condyles come down and you weight bear, the meniscus serves to support and distribute the forces that are generated by your weight bearing. If those aren't working well, then forces are distributed poorly, and that's where you get into trouble. The secondary function for a meniscus is stability. In particular, the ACL has backup stability from the posterior horn of the medial meniscus. This is the posterior horn. The back side of the meniscus is the posterior side. And when the ACL is torn, you also have a posterior horn medial meniscus. What are the tears that we're talking about? So here is an example on one meniscus of multiple different meniscus tears. So you see here the parrot beak tear or flap tear is a meniscus tear that can split into the middle of the meniscus and create a separation. What this does is it creates a free flap. This can occur by a twisting or squatting injury. Frequently happens as people get older, but it can happen in younger folks as well. We also see what's called inner rim fraying tear. That's just degenerative changes causing fraying of the tissue. Very little symptoms come from that. You can get central flap tears or horizontal tears. You can get a radial tear. A radial tear can be a significant problem because if it tears far enough, you see it here just on the inner rim of the meniscus, but if it tears far enough all the way to the periphery of the meniscus, then that's essentially the same as having no meniscus. Biomechanical studies have shown if you have complete radial tear, even though the rest of your meniscus is intact, your knee perceives and the weight forces are transmitted as though you have no meniscus. So remember that, we'll come back to that. We also have a vertical or longitudinal tear. These can be very peripheral toward the buttocks tears with combinations of all these. Also horizontal tear and a button handle tear, which is a peripheral tear that's extended, goes to the point where it becomes unstable, and then this can move around and actually cause locking sensations. So let's go back and talk about what symptoms you might have from a meniscus tear. First of all, the younger you are, the more likely it's going to be accommodated or associated with a trauma of some kind. You can have, as you get older, the meniscus tear can come from while you're running and doing a misstep or squatting, reaching in the garden, those kinds of things. But younger, it's usually slipping off a ladder, some kind of trauma, a sports injury where there's high level forces going on. That can create meniscus tears that are normally in the younger person more towards the periphery or a cleaner type of tear. As you get older, as the meniscus gets more brittle, you get more complex tears where the meniscus tissue breaks apart in many different planes. So what symptoms do you have? So for a peripheral tear, where it's just torn in a clean way towards the outside of the meniscus, you might not have any symptoms right off the bat. So what do I mean by that? So the meniscus has a couple. It's asensate. So if you have a meniscus tear, that doesn't mean you have pain. You only have pain from a meniscus tear if it moves and causes symptoms in the knee. The classic example that I talk to my patients about is the flap tear. If you have a flap tear that is torn enough so it's mobile, you can walk and twist, and that twisting or bending will create traction on the meniscus, and it will actually flip underneath itself, or it will be jammed into a corner of your knee. And when that meniscus is not lying in its normal position, then you get symptoms because it's balled up in the corner of your knee or underneath the edge of the meniscus, where when you walk on it, it feels like almost like a stone in your shoe. The symptoms come from the pressure that meniscus puts on the surrounding knee. At times, you can have actually injury to the bone. You can see on the MRI a reaction to the bone where there's stress, as though you had a stress fracture. That's where a lot of the pain comes from the stress the meniscus deformity causes on your knee. In the case of a bucket handle tear, that piece of tissue flips into the front of the knee, and it may cause it so you can't straighten your knee out. That's a locked bucket handle tear, creating a sensation of locking in your knee, scar into a position where it's no longer has its full motion. As we get older, the symptoms from the complex tears are more frequent from those displaced flaps moving around the knee and creating damage into the knee joint. So for instance, in this model here, the meniscus could tear off the backside here and work its way underneath the remaining meniscus and actually be caught into the gutter behind the meniscus on the outside of the knee. And you can see that on the MRI. And it's very common, if you see that you can take care of that in a way that eliminates the person's symptoms. Not all meniscus tears are symptomatic. Sometimes the meniscus can lay in a normal position and you don't feel any difference because it's not deformed, it's not creating a perturbation in the transmission of the forces across the knee. Then the next day, when you get up and stretch and move your knee and squat to get your dog toy from the ground again, the meniscus moves and suddenly you have symptoms. So it's frustrating for patients because they feel as though it was fine one day and then it's bad the next and it's fine again. Pain, for instance, on the inside of the knee when they're pushing against with their foot, the inside of their foot across their body. Say you're pushing a stool or a chair and they're pushing it across their body and they feel pain on the inside of the knee. That is irritating the stress, that's creating stress on the inside of the knee, and it creates pain. So when you have these symptoms of catching, of locking, of pain that comes and goes, that can be associated with catching and locking, then you start thinking about meniscus tears. But that's not the only thing that can cause those symptoms. Certainly that's not the only thing that can cause symptoms of pain on the side of your knee. You also have cartilage in that area. So cartilage can be damaged in many ways the same as a meniscus. And that cartilage, which covers the bone, can create flaps, and that can create catching. And those can cause symptoms. As well as under the cartilage is bone. And bone has a lot of nerve endings in it, and that creates pain. So if you step off a ladder wrong and come down hard on your knee, and you jam the knee and twist it, you could actually have all three. You could injure the cartilage, injure the bone under the cartilage. The meniscus blood supply comes only from the outside of the meniscus, not from the inside, and it only penetrates to the outer third of the meniscus. So what that means is when you have a tear that's in the periphery, in the outer third, say beyond this tear here, that's vascularized. That has a chance to heal. The tears on the inside of the inner two-thirds don't have vascular tear, and they have less of a chance to heal. So that one of the goals of treating the meniscus is to create a pathway for vascularity to get the areas you're trying to heal up. And we'll talk more about treatment in a second. So when you go to the doctor and you say, gosh, this sounds a lot like what Dr. Campbell described on his Facebook Live video. I had a twisting injury, I had a squatting injury, and now I have intermittent symptoms that come and go, sometimes associated with swelling, many times localized to one side of the knee or the other, and you present to your physician. The physician will do a number of tests to determine if it's likely you have a meniscus tear. We very often will get x-rays. What x-rays can tell you, particularly weight-bearing x-rays, is whether or not you have arthritis or So if you have an x-ray, a weight-bearing x-ray, and it shows that your bone is nearly bone-on-bone or close to bone-on-bone, that's a poor prognosis for making much success with treatment of your meniscus because the cartilage is already damaged beyond repair, likely, and the meniscus has probably suffered damage along the way. So if you have if your doctor takes an x-ray and it's weight-bearing and you have normal cartilage, normal space, you can't see cartilage on the x-rays, you can't see the meniscus on the x-ray, but if you have normal space, that's a good indication that there's no arthritis and the meniscus could be a factor for your symptoms. So when you do the examination, there's a number of tests that can be associated with meniscus damage. The first is checking to see if you have swelling. So what we do is we put pressure on the knee and milk fluid down towards the kneecap, and we feel with our hands on the side of the knee. That gives us the ability to feel if there's a pulse of fluid, and we call that an effusion. It's very common that if you have a meniscus tear, especially one that's been there for a while, you will have a reactive fingers along the joint to see if there's tenderness. If there's sensitivity or tenderness when we push on the joint line, that's another indicator there could be a meniscus tear. I like to stress my patients into full extension, causing them to hyperextend, and that can also cause pain. If that pain continues to be directed at the same location that the patient's been noting as his symptoms, then that can be consistent with a meniscus tear. Likewise, when you flex the knee and you go all the way down to the maximum range the patient can tolerate, and you push on it, and that hurts in the same area, that's another sign that the meniscus could be torn. And finally, one of the most sensitive tests is called the Mcmurray's test, where we take the knee and we twist the leg to grind it back and forth and put pressure on the different meniscus surfaces. That Mcmurray's test, again, consisted with typically clicking, but also with pain, can be indicating a meniscus tear. So at that point, with normal x-rays and many signs from the examination suggesting there's a concern for meniscus tear, and a good history for meniscus tear, whether you're older with trauma younger with trauma, or older with a simple squatting episode, or an episode that seems to be there by itself, using the standard elevation, ice, compression, and anti-inflammatories if the patient can tolerate it. If you've had symptoms probably for more than 3 weeks, and certainly more than 6 weeks, and you present with normal x-rays and these findings, most likely your physician will order MRI. They may not order MRI if you have a locked knee, where your knee can't come straight and the physician is convinced that you have a meniscus tear or some mechanical obstruction, and they may skip the MRI and go right to surgery. But typically we get an MRI to evaluate what the damages are, and that allows us to discuss the possibility, the treatment options for the condition. So the MRI can show us which of these tears the patient has. The resolution for most MRIs is good enough so we can separate out a flap tear from radial tear, from a peripheral tear, from a root tear. And so each of those tears has its own prognosis, depending on the individual, depending on the surrounding cartilage damage, depending on the surrounding bone reaction. So for instance, if you present with a lot of pain in your knee and the MRI shows you have a big bone bruise in the chest, put you on crutches, do gentle range of motion exercises, and allow the bone to heal and see what your symptoms are after the bone heals. We know the bone's going to heal in almost every case as long as it's given enough rest. That can take up to 4 to 6 weeks. Once that gets better, if the patient still has symptoms consistent with meniscus damage, then we move on and talk about treatment for the meniscus. So before we get into too far down the road in terms of treatments, the prognosis for meniscus depends a lot on the symptoms, the age of the patient, the activity level of the patient, the weight of the patient, the health of the patient. All these things are combined by your orthopedic specialist in determining what's going to be the best treatment for you. And sometimes the prognosis weighs heavily on that. For instance, if you have a knee that shows up on x-ray with a lot of narrowing and you're coming down to bone on bone, but you still end up with a meniscus tear, you might not have surgery because the narrowing and the damage in the joint, consistent with arthritis, is going to be the main driver of your symptoms. The meniscus tear is along for the ride, but by doing the meniscus surgery, you may not necessarily get symptoms to get better, and both you and the surgeon will be disappointed. So that all has to be factored into the final recommendations for surgery. But the prognosis for a tear, for instance, in the periphery, where the vascularity is, in a young increase the chances the meniscus will heal when you do a repair. Not every repair of the meniscus is successful. So it turns out the ACL, doing ACL surgery with your meniscus repair, will actually increase the odds of your healing your meniscus by at least 10%. So for instance, a meniscus repair by itself might heal up 70% of the time. With an ACL, heals up 80% of the time. So the prognosis for a peripheral tear is very good in a young person with otherwise normal knee anatomy. And in contradistinction, you take an older person with bad cartilage, not very good health, overweight, and they have a complex tear in the central aspect of the meniscus, then that's going to be something that's not going to heal it very well. And if it's symptomatic, you may be able to make it better. But if there's a lot of surrounding arthritis or damage to the joint, you may be able to do the surgery, but you may not change the symptoms, again, resulting in disappointment. And it may not change the long-term prognosis for arthritis, which is already starting its pathway. So we do surgery for the meniscus to try and prevent arthritis. And sometimes we do it in the face of arthritis if there are enough symptoms. But in general, if you're a surgeon, can do with you. But the prognosis for a degenerative, complex tear and an arthritic knee is not very good, as opposed to the peripheral tear with a good vascularity in a younger person. So that's all factored together in the recommendations that your surgeon will make for you, depending on your symptoms and presentation. So let's talk a little bit about the surgery. So the first surgery I'm going to talk about is the meniscectomy. That's the one that's done the most frequently. It's done most frequently because the majority of meniscus tears have poor vascularity. That's why they tear in the first place. They're weak in tissue and they don't have a chance to repair themselves from minor damage, and so they stay torn, and the flap tears can extend, creating more mobility and then some potential for more symptoms. So remember, the reason you have pain for these flap tears is because they've got caught, they've curled up, and they're jammed into one part of your knee, and it comes and goes. So the goal of the meniscectomy is to remove that damaged tissue and save as much of the normal tissue around as possible. So your surgeon will trim out the meniscus tear and contour it into the surrounding area so that as the knee moves forward. So you're saying, well, that's not good because you're missing that meniscus. Well, the meniscus wasn't working for you anyway. It's no longer giving the support that it needs, and you've stopped the damage by trimming it out, and now you preserve the rest of the meniscus ideally, and so that hopefully there will be no more tearing going forward. Now, occasionally you can have re-tears of the meniscus, but with a meniscus tear trimmed back reasonably well and smooth and contoured, you can preserve much of the meniscus and preserve much of the meniscus function for support and reduce the chance for arthritis. So what happens after the meniscectomy? So the meniscus damage is removed and the person goes back very frequently to normal activity. Now that can take a number of days or weeks afterwards. I think the community out there suggests or feels that or interprets the meniscus as a minor problem, and sometimes it is a minor problem and a relatively quick fix with a removal of the flap tear that we talked about. But oftentimes there can be more challenges. Not every patient heals it the same way. Sometimes there's scar tissue. Sometimes people So I have had a couple patients where they said, gosh, I'm ready to go. And so 2 weeks after the surgery, they're back on their feet 10 hours a day, walking on concrete floors in a warehouse somewhere. And I see them 3 weeks later, and they're in more pain than ever because their knee has now reacted to the trauma that's going on there. you've had trauma from the surgery, trauma from the injury, then the surgery, and now you're still haven't recovered fully and you're putting stress on this knee. So that can create a huge, massive bone reaction that can be extremely painful, just like a stress fracture in a runner, and that can take 6 weeks to heal up. So we pull that person out of his job again, and we put him on crutches, and we say, you have to go gradually. You have to be very careful when you go back into your work job, or your job. And in fact, over the years, I've become more conservative about returning people back to work after simple, quote unquote, meniscectomies, because if you see on the MRI there's been bone reaction from the meniscus being out of place, then it's very likely that the bone is already kind of revved up. And if you stress it, it may take off in terms of the stress, and then you'll have an even bigger reaction, and you'll have to very much react and pull that person back out of work, put them on crutches, and then everybody's disappointed. Fortunately, usually that works to save the problem, but it's disappointing that you've had to come out of work twice, once for surgery and once for the excessive reaction. So it's important, don't do it all at once, just assuming your knee is normal now that the little flap of meniscus has been removed. It's going to be normal, but it has to get there and transition from the trauma of surgery gradually back to normal activity level. So, and then it can be scar tissue. And so there can be some problems with the meniscectomies, even though the majority of patients do well and survive and have no problems. Obviously, there are complications with any surgery, and we all talk about that before these kind of surgeries, and it can include blood clots and infection and down the line. But the main issue is making sure the person recovers from the trauma of the surgery and making sure that their bone doesn't get stressed, the scar tissue doesn't form, and they stay mobilized. Sometimes we use physical therapy to do that. Sometimes patients don't need physical therapy. They can go to their local gym, get on a stationary bicycle, do their motion exercises, and do fine as long as they don't increase their activity excessively too quickly. So that's the meniscectomy. Again, very common surgery, but you still have to be somewhat careful with it afterwards and make sure you know what the goals are because space narrowing. Now, and you'll see that within 4 years. Within 8 years, you'll start to get some symptoms from that narrowing. And by 12 years, you can actually see some signs of arthritis. But many, many times we see people that have narrowing in their knees on x-rays after meniscectomy, and that's not the problem. It's the other knee that's causing the problem. And you see the x-ray and you're impressed by it, but it's also impressive the lack of symptoms. Now, that's a knee that could be at risk for if there's a trauma that you could get a flare-up of pain or problems that way. But for the most part, it doesn't seem to cause an issue. And the patients are able to return back to activity and be very satisfied with that surgery. So I'm going to go through a couple of other options now. That was a meniscectomy, which again is the most common surgery. For young people or certain circumstances, we will, and certain patterns of tearing, we will do repairs. The repair is different from the meniscectomy, and they were actually trying to restore the meniscus anatomy and the meniscus function. So there are a number of different techniques that we use, and when we do meniscus surgery, what I like to do is have all these options available. There's 5 or 6 different options that we keep in the operating room with a meniscus tear we didn't see in the MRI images, and the radiologist didn't see it. There's a meniscus tear in there, and we still have to treat it. So we like to have those things on hand to be able to take care of it. The basic tenet of the meniscus repair is suturing. So these are different examples of suture patterns that we place in the meniscus to repair them. This is an all-inside type of repair. This is an inside-outside type of repair. This is a fancy stitch that's self-reinforced called a Mason-Allen stitch, and a figure-of-8 stitch. So these are different techniques to put sutures in there. That's the basic architecture of a meniscus repair. Now, there's a lot of different ways to put those sutures in there, and we're going to go over a few of those right now. So, for instance, for many years, the quote-unquote gold standard of meniscus repair is called the inside-out repair. And so what that is you have the tear, and you take your cannula, which is long and comes from the outside in, and what you're seeing here is an arthroscopic picture of the back of the meniscus. So that cannula is being brought in from the front side of the meniscus, front side of the knee, and a long needle is being passed through it. That needle is delivered out through the meniscus, and it carries a suture with it. That suture is a stuck meniscus through here and passed at the back of the meniscus and captured with a separate incision many times here to protect the structures in the back of the knee. Those sutures are captured, and then the sutures are then tied over the backside of the meniscus to create a closure of that split. So that's the inside out type repair. That's the one that's been around longest. That's the one that we have most experience with. Here's a diagram of a number of different types of suturings. So you can have a all inside loop repair, you can have a radial tear repair, and you can have a root repair. This is an example of a repair of a horizontal meniscus tear. This is something that we sometimes will do, especially since these particular types of tears can create cysts or bubbles of fluid that go on the outside of the meniscus in the soft tissue. And that pressure from the fluid-filled cyst that is created by the flap that's created here, this little gap in here, will sometimes allow fluid in the knee joint, which is normal for the knee joint, to be trapped through the flap, and then it's captured, a cyst forms, and over time that cyst can actually get bigger and bigger, and it creates symptoms because it's under pressure and it's causing a bulge, something to create or to prevent a recurrence of the cyst. And repairing the meniscus is one way to do that. And you can see the inside out technique to do that in this way. Now, in the front of the meniscus, we will sometimes do what's called a outside in repair. So that in this case, you have a meniscus tear in the front and you're trying to stabilize that. And you have a device that has two different needles and a passing loop that allows you to pass a suture through one needle and capture it with a loop through the other needle. And that gets pulled back out to the front of the knee, and that loop of suture now is tied around the front of the meniscus, and that closes it down. So that's called an outside in, and that's generally used for meniscus tears in the front or anterior aspect of the knee. Here's another example of the outside in, the inside out, and then we also have the all inside repair. So the all inside repair, it can be done a number of different ways. There are devices that have been evolved over the years. I won't go into great detail about the old forms of this technique, but basically they are now all based on a suture construct into the knee. These are pre-tied, so when they're delivered, the suture implant goes into the back of the meniscus. The suture then, and again, there's two implants with a loop of suture between them with a pre-tied knot, and those are cinched down and close the meniscus tear in that way. Now there's other ways to do all inside repairs. There's a device that can deliver a suture. As you see here, this is a clamping device that has a suture that's attached in its jaws. The jaws go into the meniscus. You bite the jaws down, and the mechanics of the clamp allow the stitch to be passed from the bottom to the top, and there's a grasping fixation device which allows the meniscus to be trapped in the upper jaw, and that gets pulled out, and then you can tie it that way. And then the final meniscus repair technique is a root repair. Again, the root repair is where the tissue is torn loose from the bony architecture, typically is in the backside. A loop is placed through the back of the meniscus, and that loop goes down a little bit. The knee suffers again like it is, just as like there's no meniscus in the knee. It's as though there was a complete meniscectomy because it's detached and the body responds as though there's no meniscus at all. So that creates increased stress to the knee, increased breakdown of the cartilage, breakdown of the bone, and then your arthritis. So after these repairs, the recovery is longer for repair. You're protecting the meniscus so it can heal. That means you're going to be on crutches for 4 to 6 weeks, sometimes longer, sometimes shorter, depending on the type of repair it is, how the repair was done. And you often will have limited motion to begin with, so the motion the bending does not put stress on the meniscus, typically in the posterior horns of the meniscus repairs are done, because that can create stress on the repairs and cause them to fail. Once you're off the crutches, then your progress is tolerated, but it's a slower process because we're waiting for tissue to heal than even an ACL reconstruction, where the tissue you put in heals typically to bone. The meniscus heals soft tissue, and that's a slower process, and you have to wait for the strength to get to sufficient so you can run and jump on that, which can take 4 to 5 to even 6 months. So that's this. We can go into great detail about that if you want, but in the questions. But the main thrust today is to know what the meniscus does, how it presents, and then follow along with what your doctor is going to do to help you take care of that.
Thank you, Dr. Campbell. We have time for a few questions, and some of the questions that we are unable to address in this Q&A period, we'll give a written response to, and that will be posted to the event page. The event will be archived. You can share it with friends or family members who are interested in their meniscus health. I want to congratulate Dr. Campbell because he received his 4th consecutive Coastal Virginia Magazine Top Docs Award for 2021. And that is voted upon by his peer physicians. And there is no greater testimony to a physician's quality outcome. 2 quick questions, and this from our Facebook audience. Question number 1. My MRI shows a complex tear of the medial meniscus. How is this different from general tears? I won't see my ortho until next week. Thank you. That's the question.
So this is an example of a tear that you might have. This is called a complex tear, and it's complex because it's torn in more than one plane. So a radial tear goes like that. A flap tear has a curved tear. A peripheral tear is more vertical, but a complex tear can be all combinations of those. And so the complex tears can be very unstable and cause symptoms by the fact that they actually are very mobile, and they can move into a bad position in your knee where they're not supposed to be. And when you walk on those meniscus flaps that are balled up in the corner of your knee, they can cause symptoms. A general tear, it's hard to know what a general tear exactly is because there's so many specifics, but the average tear, I would say, would be more of a flap tear, where you have a simple plain tear which comes from the inner avascular area of the meniscus, and it tears into the body of the meniscus, and that can also present symptoms. But the complex tears have multiple flaps, and they can be very uncomfortable, and they can also...
Dr. Campbell is a cyclist, and here is a question that he will like. The question is, biking seems to be the most recommended exercise for those people with bad knees. However, my knees hurt after biking 8 to 10 miles. Some of the trail is mildly hilly. Do you have any suggestions?
So that pain you have after biking may be more related to your patellofemoral joint, which is the bone. The patella, of course, is the kneecap. And when you bicycle, the biking is generally recommended for bad knees because it's less stress on the weight-bearing surface of the knee. But remember, there's 3 compartments to your knee. You have the inside and outside compartment, and with vertical activity such as running or walking, that can cause damage or pain in those areas where you've had meniscus damage or cartilage damage or arthritis. But you can also stress the kneecaps. Now, the kneecaps are more stressed in bent knee activities like biking. So if you are doing 80 cycles per minute on your bicycle and you're going back and forth, you can see your kneecap has to run through that bend type classes, and that puts more stress because you're standing in the pedals now and you're bending your knee. And so many times the biking is good, but if you have a lot of patellofemoral pain, then you may be one of those people who has to consider doing something that doesn't cause as much knee bend with stress. So you might actually do better, depending on your knee condition, with swimming, a flutter kick, while a whip kick, where you're bending your knee more, might not be so good. So a flutter kick or walking on flat ground instead of walking on hills may be better exercise for you or less pain than doing the actual biking, especially up the hills.
Another exercise, activity-related question. Here goes. My symptoms started a few weeks ago. Stiffness of knee from sitting, heaviness, and some inflammation behind the right knee, like calf area and up. My interest is now to set aside my dance routine and focus on strengthening my knee area. Do you recommend swimming, physical therapy? What kinds of exercise? Thank you.
Okay. So, hopefully you've been able to see your physician or your orthopedic surgeon, and you've been able to get an examination while you're waiting for the MRI, and they can begin formulating a treatment plan based on the examination. You mentioned inflammation, you mentioned stiffness, you mentioned pain or swelling behind the knee. Those things can all come from meniscus tear. They can come from cartilage damage. They can come from simple swelling of the knee caused by other reasons for irritation. Sometimes when people sit for a long time, that pesky kneecap is put under pressure and it can create pain, which we call a positive theater sign. When you sit in a theater or sit in a car when you drive to Richmond, that can create pain in the front of the knee. And in fact, sometimes that patellofemoral pain can actually cause referred pain to the back of the knee. There can also be fluid in the back of the knee in the form of a Baker's cyst or popliteal cyst. So that has to be differentiated by physical examination, and that will turn up on the MRI most likely as well. But if it's pain and swelling around the kneecap, where the symptoms are around the patellofemoral joint, that can often respond to physical therapy. If it's more catching, mechanical problem. So I may have answered part of your question. I'm not sure I answered all of it, but we can certainly talk more about that on follow-up questioning.
Thank you, Dr. Campbell, and thanks to all the participants who joined us today. That's all the time that we have for now. So we will see you at OrthoVirginia. We will see you at upcoming Facebook Live events. And thanks to everyone. Keep cool.
Thank you. Stay safe.